Hi, everyone. My name's Eloise, and I'm part of the partnerships team here at Nerva and Mindset Health. And I'm thrilled to be your host for today's presentation on dysautonomia and digestive health with our lovely guest speaker, Nancee Jaffe. So Nancee is the founding dietitian for the UCLA Vachi and Tamar Manoukian Division of Digestive Diseases and owner of Nancee Jaffe Nutrition Services, which is a concierge GI nutrition practice. Nancee was recruited to UCLA in 2012 to help develop a comprehensive GI nutrition program to enhance care for patients with specific nutritional issues and to provide ongoing nutritional education to UCLA GI fellows, gastroenterologists, and other healthcare professionals. Under her leadership, the GI nutrition program became the largest in the United States, with 8 full-time digestive expert dietitians before she left the leadership role to start her private practice. Nancee shares her expertise on nutrition and digestive disorders by speaking at national conferences and also speaking with us here today. Nancee spearheaded an effort to formalize a GI-specific dietitian group housed jointly under the American Gastroenterological Association and the Academy of Nutrition and Dietetics, which became official in 2020. She's also the committee lead for the Rome Foundation Diet and Nutrition section. In her spare time, Nancee is a dancer and an artist, currently apprenticing as a bookbinder in Hollywood, California. And we are so thrilled to have you join us today, Nancee. Thank you so much. We are very excited to hear the latest research, some practical tips, and I will pass it over to you.
All right. Thank you so much, Eloise, and hopefully everyone can hear me and see my slides. It's really an honor to be here. So first of all, good afternoon from Los Angeles, California. You'll notice that the title of this presentation changed a little bit. As I was thinking about how to present this topic, I realized that just focusing on IBS would be a disservice. That IBS is just a small part of the digestive conditions and symptoms and illness and issues that you're going to see when you meet with dysautonomia patients. So we decided to change the title to Digestive Health and Dysautonomia. And this is a topic that's very near and dear to my heart. So I've been working with dysautonomia patients since about 2018. I was actually shocked by being the first point of contact for a lot of these dysautonomia patients when I was at UCLA. They would find their way to me looking for me to help them get to the right cardiologist, neurologist, gastroenterologist, etc. And so I started to really see that these patients needed and deserved a really good comprehensive care team, especially of people who knew about this condition. And as you'll see, this condition is becoming more and more and more prevalent. And we'll see this as we move through the presentation. So this topic may be familiar to some of you who are listening. And for others, this may be one of the first times that you're hearing this term dysautonomia. So I wanted to make sure that we start from a really clear understanding of what dysautonomia is, where it comes from, who it's affecting. So I'm going to spend probably the first quarter to a third of this presentation just making sure we're all on the same page. And part of why I feel like this is imperative is patients, as I mentioned, have a really hard time finding providers who understand them. And it's a really big issue that these patients get gaslit by the medical community and get very, very frustrated, which they deserve to feel frustrated. They're not getting the care that they deserve. And one way that as providers, we can build trust with this community is by showing them that we can use the terminology and we understand what they're saying when they talk with us. I've had so many patients saying to me, wait a second, do you have dysautonomia? I'm like, I don't, but I've been working in this area long enough that hopefully I have a pretty good idea of what you're saying and able to be with you in it and actually understand what you're saying. So dysautonomia is a huge topic. And almost every slide that I'm going to present on, especially when we get to the GI manifestations, could be its own 45-minute lecture. So my hope is that this will be a really useful overview tool I have given Nerva permission to give these slides out. If you want a copy and they're useful to you, please take them. Because I want to make sure that the more of us that are armed with this information and the more of us that are able to help these patients, the better. So hopefully this is a really good starting point and a good reference for working with this patient group. All right, so let's start with a refresher on the nervous system. So as you may remember from your basic science class, there are two main parts to the nervous system. There's the central nervous system and the peripheral nervous system. Okay, so the central nervous system is consisting of the brain and spinal cords. You can see in the image we have here, but it is what is listed in pink. And its job really is to collect information from the sensory nerves, send it up to the brain, have it processed and responded to, right? Whereas the peripheral nervous system consists of nerves outside of the brain and spinal cord. So again, in our image, you can see this in yellow. And you may hear me say CNS and PNS throughout this lecture on describing the central nervous system and the peripheral nervous system when I say those terms. So the peripheral nervous system plays a key role in sending information from different parts of the body up to the brain, as well as carrying out any commands that might come from the brain to different parts of the body, right? And some of this is automatic, and some of it we have control over. So let's dive a little bit more into the PNS, which can be divided into a couple more subsystems, right? So under our PNS system, we've got our somatic nervous system and our autonomic nervous system. So really quick, somatic nervous system, this includes muscles that we have control over, plus all the nerves throughout the body that carry information from the senses, except for vision, which has its own system. But really the part of the body and the part of the nervous system we are going to focus on together today is the autonomic nervous system. Okay, so autonomic nervous system is automatic functions that the body does that are necessary for us to survive, right? So these are processes that we do not think about that happen while we're sleeping, they happen while we're awake, and that if they didn't happen, we would cease to exist. So the really important things that are happening every single minute, every single second, every single day of our lives. And of course, this area can then be further subdivided into our sympathetic nervous system and our parasympathetic nervous system. And these are probably parts of the nervous system that you know fairly well. Our sympathetic nervous system is the one that we think of as flight, fight, and freeze. It's that stress response. And then we've got our parasympathetic nervous system, which is responsible for resting and digesting. And I like to think of these systems as a light switch. They can't both be turned on at the same time. So when one of them is off, the other is on. And this is important because in dysautonomia, the light switch is going a little bit haywire. And we'll talk about that in a couple of slides. Now, since we're all talking about gastroenterology here and digestive health, we have to bring up the enteric nervous system, or the ENS. So this is part of the autonomic nervous system. It's not generally considered its own category, but it is the largest and most complex part of the peripheral nervous system. It really does deserve to be called out as one of the subsystems. And this is located in all of the walls of the GI tract. It goes all the way from the esophagus to the anal. And although it receives information from the central nervous system, and this all comes through the vagus nerve and through the spinal cord, it has been shown very early on that this system can act independently of the central nervous system. So there is automatic responses that are happening, and then there are some that we can be in control of. So how does the autonomic nervous system impact the organs, right? So the brain needs the autonomic nervous system and its various network of nerves to help the organs function. For example, with our skin, the autonomic nervous system controls the ability to sweat. Okay, and that makes sense because we think about when we are under fight, flight, or freeze, stress is part of that equation, right? Also, the heart and the circulatory system, the autonomic nervous system regulates how fast and how hard the heart will pump. It also is in charge of the width of the blood vessels, and this can have a direct relationship in managing heart rate and blood pressure. And this is going to be really important in dysautonomia. And then, of course, with our digestion, we know that autonomic nervous system is in part managing the digestive process. We don't think about boluses moving through our esophagus, through our stomach, through our small intestine, into our colon. We don't have any control over that, right? It also is part of what holds some of the muscular control for defecation. So we know that we've got two sphincters in the anal canal, one we have control over, one we do not. All right, so hopefully that was a nice refresher on what the nervous system is so that we can now get into what dysautonomia is. So dysautonomia refers to a group of medical conditions caused by problems with the autonomic nervous system. And as you heard me say, and you saw on the last slide, this involves involuntary body functions that can affect multiple parts of our body. Okay, so you can see these are just a few of the ones that we see. Okay, so how prevalent is dysautonomia? So dysautonomia worldwide affects more than 70 million people. It can be present at birth or appear gradually or suddenly at any age. And the majority of the patients, I would almost wager to say all the patients that are going to end up in your clinic are going to be of that latter type, where it has come on gradually or oftentimes very suddenly. I have so many patients say to me, I used to be an athlete. I used to be running marathons. I used to be really active. I used to be the primary caregiver in my household. And now I'm not able to do a lot of these things anymore. So it can really hit someone out of the blue and very, very suddenly. As far as we know, it affects men and women equally. And to this point, there's at least 15 distinct forms of dysautonomia. And we'll be focusing in on one specific form, which is the one you're most likely to see in your clinics. The incidence has increased with long COVID, and we'll talk a little bit more about that in a few slides. And we believe that somewhere between 1 and 3 million people in the US are estimated to have POTS, and POTS is that main form of dysautonomia that we will be focusing on. And this is a condition that is labeled as one of the invisible illnesses, right? So these are patients who outwardly may not appear sick, and this is part of why the medical system can dismiss these patients, but they are experiencing significant symptoms and it is impacting their daily lives and especially their quality of life. So these patients really deserve to be seen and heard and understood. So I'm not going to spend a lot of time on the symptoms because, as you can imagine, there are as many symptoms as there are organ systems and autonomic functions that can go wrong. And so I just wanted to instead put graphics from some of the major organizations that are working with dysautonomia up on the screen. So we've got the Ehlers-Danlos Society, the Dysautonomia International Organization, and then I believe the one at the bottom of the screen, I didn't write it down. I'm so sorry. I'm blanking on which one that's coming from. It might be the Los Angeles Dysautonomia Network. So it's really important that we're just aware of all the different ways that our patients may be impacted by dysautonomia. So there's primary and secondary causes for dysautonomia. We're not going to spend time on the primary list. I did want you to have them because, again, hopefully you'll be getting copies of these slides, and it's just important that you see that there is a congenital or genital basis for some forms of dysautonomia. But the reason why I'm not spending too much time here is these, at least in my experience, are not the main ones that are showing up in my clinic. I've gotten a few over the years, especially the FD version, but for the most part, they're going to be the ones coming from the secondary causes. And that's why I want to really focus this lecture on the secondary causes that we see in dysautonomia. So here is a list that is by no means exhaustive, but at least it gives you an idea of some of the many varied reasons why dysautonomia can present. And for the purposes of this presentation, I'm going to be focusing on the ones that just popped up on the screen. So we're going to start with POTS, okay? And POTS, within POTS, I'm also lumping in other orthostatic intolerances. And just so you know, orthostatic intolerance literally has to do with the ability to stand up without symptoms. So orthostatic means standing up. So this condition is defined as low blood pressure that occurs with the act of changing body position, specifically going from line. down or sitting to a standing up position. We're going to spend some time on disorders of the gut-brain interaction. We're also going to talk a little bit about hypermobile Ehlers-Danlos syndrome. And just for those of you who are not familiar, it's a genetic disorder that affects the connective tissue, primarily the joints, and is characterized by excessive joint mobility, leading to instability and pain. And within this hypermobile form of Ehlers-Danlos syndrome, I'm including for the context of this lecture, hypermobile syndrome disorders. And the reason that I'm doing that is the same reason I'm doing it for orthostatic intolerance as we talk about POTS, is that not all of your dysautonomia patients are going to get the official diagnosis of POTS or the official diagnosis of hypermobile Ehlers-Danlos syndrome. But that doesn't mean they don't fall on the spectrum. That doesn't mean they're not having some form of orthostatic intolerance or some form of joint instability or hypermobility. And so a lot of the things that we're talking about still hold true for those patients who maybe don't have that official diagnosis. And then we're going to go into mast cell activation diseases, also known as most specifically, we're going to focus on mast cell activation syndrome, because this is the one that's been most studied in the literature as it pertains to dysautonomia. And then we will also be looking at histamine intolerance. And then before we do that, really quickly, I just want to touch on, oh, I'm sorry. Yes, let me hide this. I'm so sorry. Here you go. So let's start by touching on the role of long COVID when it comes to this condition. Or actually, I'm so sorry. Would help if I finished my conversation on this. So the reason that we're focusing on these areas is that finally the medical community at large is starting to see that there are strong connections. So for a long time, these conditions have been looked at together, but our GI groups were not really looking at these conditions and thinking about them as what is now being called in GI the triad, what for a long time has been called the trifecta. And so we're really going to be focusing in on this area. And I'm glad to see that there's upcoming lectures that are going to be happening at other conferences all across, at least in the United States. I'm glad to see that our community is really embracing this and really looking at this. So dysautonomia is considered an umbrella condition, right? And overwhelmingly, the research is starting to pull some of these major conditions together and starting to connect them, right? And I do want to acknowledge that we're going to be focusing on the POTS form of dysautonomia, and we're going to talk about that in just a second. So technically, POTS could be put up in the top body of the umbrella. It could be POTS dysautonomia labeled up there. The reason why I put it as one of the spokes is it has specific nutrition interventions that can really help your patients, as do MCAS, Ehlers-Danlos syndrome hypermobile form, and DGBIs. And so I feel like it deserves a place on the spokes of the umbrella. So let's talk about POTS for a second. So as I mentioned, POTS is the most common form of dysautonomia. And because I already have 57 slides to share with you guys, I don't have a slide dedicated to nutrition interventions on POTS, although I will be sharing some of my thoughts about it towards the end of this lecture. Given that it's the most common secondary cause for dysautonomia, I think it's really important as care providers that this is something we are comfortable discussing with our patients and understanding what it is. So just to give you a brief overview on POTS, when a person with POTS stands, their body has trouble adjusting the blood pressure and the heart rate, okay? And this can lead to orthostatic intolerance, meaning they have difficulty standing for extended period of time without having symptoms. And a hallmark of POTS is a rapid increase in heart rate. We all know this as tachycardia upon standing, typically exceeding 30 beats per minute within 10 minutes or reaching a rate of 120 beats per minute or more. And this can come with all sorts of symptoms, not just changes in heart rate, but it can come with dizziness, lightheadedness, fainting, heart palpitations, shortness of breath, fatigue, and brain fog. And I can tell you, if POTS is not well managed, it's not uncommon for me to get on a call first time meeting a patient and they're lying in bed. They're not able to sit up. They're not even like they can move their head, but other changes to their body position cause a lot of distress and symptoms. So this is important that we understand what can happen in our patients who have POTS and why this can affect, we're going to talk in a second, their GI symptoms. So causes and risk factors for POTS. So there can be a family history. It's not uncommon for there to be a genetic predisposition towards POTS. But more and more, we're seeing now that there are underlying conditions, specifically viral infections, traumas, autoimmune diseases, which are likely to lead to some of the POTS that we're seeing in the secondary form of dysautonomia. And especially with COVID-19, POTS-like symptoms have been observed in individuals with long COVID. The other part is I'd want to acknowledge it's not just our long COVID patients who can have this, it's our long vaxxers. So some of you have maybe met patients where their dysautonomia symptoms did not start after they got COVID. They started after they got the vaccination. And so unfortunately for some of our patients, they did have these long COVID symptoms starting with inoculation. And so you may meet some long vaxxers through this process. So let's look at really quick, just one slide on dysautonomia and long COVID. So POTS affects, it's believed, about 30% of those with persistent long COVID symptoms. I would argue this is a gross underestimation. And I think that we will see as time goes on that more and more of our long COVID patients are actually being transitioned into the term dysautonomia. And estimates vary widely, but when I first started looking at the statistics on dysautonomia and long COVID, they thought it was maybe up to 50 or 60% increase in dysautonomia. We're now up to 79%. So we're seeing quite an uptick in the number of patients who have dysautonomia because of experiencing long COVID. And some theories as to why this is happening. So we're not sure. We're not sure if it's that antibodies that were created as part of fighting COVID have actually attacked normal functioning of the autonomic nervous system and made it malfunction. Possibly that there's low-grade or chronic inflammation that is triggering that light switch, as we talked about, the fight, flight, freeze part of our autonomic nervous system and is throwing it out of whack so that it's misbehaving. It's also possible that there were other viruses hiding out in the system that COVID kind of awoken and the body now is struggling to clear. We also believe that in some patients, overactivation or overreaction of their immune system can lead to the autonomic nervous system malfunctioning. And as you see, this can cause vagus nerve inflammation. We know how important the vagus nerve is to our GI tract, to the signaling that's going on the brain-gut axis, and to how our GI system is going to behave because of that. There's also ideas that viruses may be entered the brainstem, so affecting the central nervous system, and this can damage areas where communication happens between the autonomic nervous system and the central nervous system, leading to dysregulation. So it'll be really interesting as the years go by and we learn more. We'll see what we end up learning. All right, so I'm not going to spend much time on this. Again, I'm really doing this so that when you guys get a copy of the slides, if you're about to have a dysautonomia patient show up to a session, hopefully this will be a nice quick review for you. So some of the testing that's done, we call these autonomic function tests or autonomic functioning tests. Oftentimes patients complete a battery of these tests before they are officially given the diagnosis of dysautonomia. So tilt table testing is mainly to look for POTS. There's also thermoregularity sweat test or QSART. So basically, one of them is a qualitative test, one is a quantitative test. Rarely have I seen patients go through both. I would say more frequently patients are going through the QSART version of the test. Again, the goal isn't that as ancillary medical providers that we can read these tests or be able to talk with the patient about the results. That's not our job, or at least that's not my job as a dietitian, but understanding what a patient has gone through and then what it means that the QSART is showing sweat, the ability to control sweating, right, which we said the autonomic nervous system is in charge of. Also checking blood pressure and heart rate changes with a breathing test called the Valsalva. Then there are lots of different blood tests that are being done. Some of these are really interesting new tests. At least they've been new to me as I've been learning about this community, that can really help the different specialists who are going to be on the team understand the extent of autonomic dysfunction that could be going on, which can make it different in terms of the types of treatments these patients might do. There's also ECG, EKG, and then you notice I list a bunch of other things that could be going on. And then under that first, you see GI tests. Well, just to make sure we are understanding what types of GI tests I'm describing, specifically the digestive conditions that we are seeing in dysautonomia patients, you're most likely to see your doctors, hopefully, go for a gastric emptying study, anal rectal manometry, and possibly some transit studies, which could include scintigraphy, motility capsules, etc. All right, so getting back to our main focus here, now that we hopefully are all on the same page when it comes to dysautonomia, what it is, who is affected, how it's diagnosed, let's actually move into these conditions, start to see how they overlap with one another, and we'll get into the GI and how that works. So you'll notice that not only in my little drawing that I created here does dysautonomia overlap with these other conditions, but they overlap with each other, right? And unfortunately, this can make understanding what is causing what a little bit of a muddled mess, but it also means that we are helping our patients to feel, again, so much of the time they're made to feel like they're crazy and they're not. And if we can help them to see that, yes, there are overlaps of these different conditions and that it's not in their head, they really are experiencing this, it can be really validating to them that up to 80% of dysautonomia patients have hypermobile Ehlers-Danlos syndrome, that somewhere between 31 and 87%, again, the research is really varied on this topic, of dysautonomia patients have MCAS, and that up to 46% of dysautonomia patients have IBS. And again, this is part of why I changed the title of my lecture is when we think about it as DGBIs, when we think about it as these disorders of the gut-brain interaction, that number would skyrocket, right? I would even say 46% is probably a conservative estimate, but if we're only looking at IBS, then maybe that number makes a little bit more sense for us. So let's get into some of the details about the diagnoses and the prevalence of GI conditions. So when it comes to hypermobile form of Ehlers-Danlos syndrome, 70% of patients experience some combination of heartburn, regurgitation, epigastric pain, nausea, postprandial fullness, and belching. I don't know about you, but that sounds like functional dyspepsia to me, right? And we do see that there is potentially a 50% crossover with functional dyspepsia in these patients and about 40% crossover with irritable bowel syndrome. There's also a high likelihood of pelvic floor dysfunction in this particular group. And that in one study, 59% of patients studied had some sort of esophageal dysmotility. And that we also see a high level of delayed gastric emptying in this group. All right, what about with our MCAS patients? So GI symptomology related to MCAS is frequently misdiagnosed as a functional gut disorder. Right? I'm going to talk about each one of these categories in a second and give you some resources for them. There are amazing lectures dedicated to this topic and how we can start to tease out what is MCAS, what is IBS, what is functional dyspepsia, but then also looking at how they cross over with each other. 57% of these patients may experience nausea and vomiting, 14% have constipation. And then what about our POTS or dysautonomia POTS patients? So this is what I think is really important. Parasympathetic nervous system activity might be lower in patients with IBS. So you already heard us say when we were talking about long COVID that there's something going on with that light switch and that they're almost stuck in the sympathetic nervous system, in the fight, flight, freeze. And then we're seeing that POTS patients specifically have lack of ability to get into that parasympathetic, which we know is our rest and digest, right? If we're not resting and digesting, we're going to have GI issues, okay? Symptoms of peripheral and enteric neuropathy have been seen in our POTS patients, so a lack of sensitization, which can also affect things like the sphincters, and there might even be some hypotensiveness going on in the area. We also have a very high prevalence of nausea and abdominal pain in these patients, as well as small bowel dysmotility and visceral hypersensitivity or sensitization. So let's really get into some of the GI that we see here. Okay, so for the purposes of this lecture, I mean, as you can imagine, every one of these topics could be its own hour-long lecture that we give, right? So this is a way, hopefully I'm taking you a little bit into my brain and how I've found working with these patients has become a little bit easier for me, because it can feel very overwhelming, especially if you're not used to seeing patients that are this complex, because these are very, very complicated and complex, beautiful patients. So one way I like to think about it is, as I'm thinking about their symptoms and I'm hearing them talk about their digestive upset, I put them into three distinct yet very highly interconnected categories: dysmotility, DGBIs, and then MCAD, histamine overload, MCAS. Okay. And you'll notice that even though I created a hierarchy, I purposely did not draw lines connecting these categories to specific conditions or symptoms, because I think that that would be making assumptions about connections that are not true. Every individual case needs to be looked at independently, and we need to figure out. So even though I list constipation under dysmotility, it can just as easily fit under DGBIs, possibly even under MCAD. I just find, majority-wise, and the patients I'm working with, the dysmotility I'm seeing in these patients is gastroparesis, constipation. Under the DGBIs, I'm seeing a lot of functional dyspepsia, nausea, vomiting, SIBO, IBS. And then with our MCAD, abdominal pain, GERD, and diarrhea. And again, this is my experience working with these patients. So I'm going to apologize up front. Each one of these topics is going to be kind of covered in a brief way. But again, my goal with this was that you would have a really nice reference for when these patients come and visit you of what you can do. And luckily, there's another reference that you can go and print as soon as you finish this lecture, which are a new set of guidelines. Not really guidelines, they're really more best practices that came out from the AGA in July of 2025. The GI community finally is starting to recognize, I mean, we've had leaders in this area for a long time, but I feel like this is the first time I've seen a paper like this, where it is kind of a call to arms of, we can't, as GI professionals, pretend that this isn't happening. We can't pretend that dysautonomia doesn't exist, or that the triad or the trifecta, whatever you want to call it, exists in these patients. And so this is really starting to ask the question, how should we be looking at these patients? How should we be helping to figure out when we have one of those patients in front of us if they haven't gotten fully diagnosed? And so what you'll see is the writers are the first to admit that there's poor amount of understanding around these overlapping conditions and that there's insufficient data. And at the same time, we need to be on the lookout, and we need to be helping our GI doctors, if you're an ancillary provider, understand what these conditions might be and how they might be able to help with them. So as we move through the rest of this presentation, I will be bringing up these best practices just to show how, as a community, maybe we can better work with this patient group. But I was really glad to see that this article came out, and I'm especially proud of my colleague, Andrea Shin at UCLA, who's one of the writers on this topic. So let's start with the category of dysmotility. So dysmotility, just to remind us, refers to conditions where the muscles in the digestive tract, whether it's the esophagus, the stomach, the small intestine, the colon, are not functioning properly, right? And this can lead to impaired movement of food and waste through the body. It does not automatically mean a slowdown. It could be a slowdown in one area and a speed up in others. We have seen that in some of these conditions, they may have increased gastric emptying. The majority, I think I could say, have a slowdown, but it's not a guarantee. Dysmotility just means dysfunction, right? So the first one that you're going to see a lot with these patients is gastroparesis. So this is one of our upper gut dysmotility. So gastroparesis is a condition where the stomach empties its contents into the small intestine slowly and or incompletely. And this delay in gastric emptying is caused by dysfunction in the muscles and or the nerves that control stomach motility. And I kind of like this little pictogram that's up here, which can show some of the reasons behind that dysmotility. And there's all sorts of symptoms that you will see with these patients. A lot of you are probably already familiar with this condition, so I won't belabor it, but I did put some of the symptoms up there for you. It can also lead to pretty significant nutritional impacts, including and especially inadequate intake. And this can lead to vitamin mineral deficiencies, electrolyte imbalances, weight loss, malnutrition, and all sorts of things, right? So when we're thinking about this patient population and you have a patient who's describing some of these symptoms, hopefully they've had a gastric emptying study or they've worked with a really good motility specialist and have gotten a diagnosis of gastroparesis. One thing that we want to make sure is we're talking with them about volume. The ability of the stomach to accommodate a meal is impacted, right? We know that this is part of what goes on with gastroparesis. So we need to be thinking about smaller, more frequent meals. We need to be thinking about density of the nutrition, not the size of the volume. We need to be shrinking the volume down, but making it as nutrient dense as we possibly can for these patients so that we do help them avoid those vitamin and mineral deficiencies and possibly malnutrition. We also know that fat activates cholecystokinin, which can result in a relaxation of the fundic area, inhibit antral motility, and delay gastric emptying. So some patients find that they do better if we reduce or change the type of fat. Liquid fat is often better tolerated than solid forms. And we also may want to talk with them about fiber. I don't like to talk about low fiber. I like to talk about changing the type and particle size of the fiber that we give to our patients because high intake of insoluble fiber reduces antral motility and delays gastric emptying. We also may want to talk with our patients about liquid versus solid meals. So that may mean that if we're going to give them, want something more insoluble in fiber, we might want to puree the hell out of it because all of a sudden that can make it move a little bit easier through the stomach. We also can consider things like oral supplements, smoothies, blenderized meals, etc. And if you're wanting more information on this topic, for those of you who attended DDW this year, Emily Haller, shout out, amazing dietitian, gave a brilliant lecture on the nutritional ideologies, impact things we can do for gastroparesis. And her video is available on the DDW site, so I highly recommend that you go and watch it. All right, so I chose to put constipation in this area because I see a lot of slow transit constipation and dyssynergic defecation or pelvic floor dysfunction in this group of patients. And so for our patients who have these conditions, we're probably going to be looking at some moving agents. So hopefully they're working with one of our GI doctor colleagues. They may be offered things like osmotic laxatives, which can include magnesium oxide or PEG 3350. Stimulant laxatives, including bisacodyl and senna. Senna for a long time was stigmatized. And we thought, as I know I did as a GI provider, that I was not supposed to be offering senna. Well, it became part of our guidelines, the ACG guidelines in 2023 for chronic constipation. So it is one that I will use with these patients and it can be very effective. Stool softeners, prokinetics in this group can be very helpful. And then our doctors may recommend things like secretagogues, such as lubiprostone, plecanatide, and linaclotide, or even vibrating capsules, suppositories. As a dietitian, of course, I want to intervene with food whenever I can. So we may want to do things like kiwi. And again, if a patient has gastroparesis on top of it, we may want to puree that kiwi, take the skin off. That might make it more tolerated by them. But it is IBS friendly. It has good fiber and enzymes that can really help with GI motility. Possibly prunes if your patient is someone who is not sensitive to sorbitol, it doesn't create gas and bloating, then we can offer this to them. And especially again, if they've got kind of severe dysmotility, we might want to go with prune juice, which in the evidence, as little as 2 ounces of prune juice has been shown to be effective for helping this patient population. And then, of course, cold flax and chia only if their motility allows for it, but it can be very helpful. And then for dyssynergic defecation, pelvic floor dysfunction, this is where I give a huge shout out to our pelvic floor physical therapists. If there's any on the call, you guys are amazing. You are brilliant. And the work that you do with our patients, with the group of patients we all work with together is, I mean, they need you. They need you badly. And so knowing the good pelvic floor physical therapists who can work with these conditions in your area and being able to offer those as a resource to your patient, really important. Squatty potty, often recommended, and possibly even biofeedback, especially if they failed the balloon expulsion part of the ankle rectal manometry. All right, another very simplistic slide on a very complicated topic. So for the purposes of this lecture, I'm just calling it hydrogen predominant SIBO and intestinal lymphogen overgrowth. You can see the symptoms run the gamut in terms of what can show up in this patient population. There is evidence there could be vitamin and mineral deficiencies, micronutrient maldigestion, malnutrition. I would argue a lot of this is due to over-restricted diets, right? There's a lot of really bad and, in my opinion, pretty dangerous suggestions about how patients should be restricting their diet in order to try and cure SIBO. And I think we all know, hopefully, and if you don't, here it is, there is no evidence-based studied diet for SIBO at this time. No one studied it. And so diet is not the cause or the cure, as far as we know, but it can certainly help manage symptoms. So that's really where someone like me, the dietitians who are listening, we can be really helpful by helping to aid with symptom management. So in your IMO patients, we might be looking at things that can help constipation, like on the slide previously. We can consider a low FODMAP diet, which is known to help for abdominal pain, bloating, distension, if those are present in our SIBO patients. So to finish up dysmotility, let's go back to our best practices. So again, I've pulled out a couple of the best practice advice that have been put out there, including diagnostic testing for functional defecation disorders should be considered in this population. Those with chronic upper GI symptoms should get motility studies. And I love 15, besides general nutrition support, special diets, including a gastroparesis diet, should be considered and done with nutritional counseling or guidance to avoid restrictive eating patterns. So hopefully we're seeing that the guidelines are supporting some of the work that we're doing, and maybe more patients are going to get it diagnosed the way that they deserve. All right, so DGBIs. DGBIs are very common in our dysautonomia patients. Studies of POTS patients alone showed that there's a high prevalence of things like nausea, abdominal pain, and constipation. I could have spent a whole lecture on functional dyspepsia, which I think is really prevalent in this group. But since I did promise to talk about IBS a little bit, I felt like I should throw it in here. So hopefully this is a reminder to most of us that the Rome 4 criteria for IBS includes pain alongside a change in form, frequency, and or how the pain resolves or changes with stool passage, including the different subtypes that we see listed here. And I've always loved this graphic. This is such a great graphic that was done by Michigan, Lori Kiefer. We've also got Peter Gibson on here. I think it's just a great way of reminding us that this really requires a multimodal integrated care team. We've already talked about constipation, but as you'll notice, when it comes to IBS, there might be more use of SSRIs or SNRIs, along with some of the others, maybe less focus on our prokinetics. With our IBS-D patients, antispasmodics like hyoscyamine, Bentyl, antidiarrheals like loperamide, bismuth, Lomotil, our SSRIs, SNRIs, and tricyclic medications. And then, of course, where would we be without our gut-directed therapies? This should never be overlooked as treatment in these patients. Both in my private practice and my work at UCLA, I am constantly referring patients to Nerva. And then at UCLA, I'm really lucky that we've got 5 highly skilled GI health psychologists that have become like a really important key part of care. If you're not familiar with the Rome directory, there is a gastrocyte group as part of the Rome Foundation, and they have created a directory where you can find the providers that are near you or near your patient who offer gut-directed care, because we know not every therapist knows how to do gut-directed therapies. So it's really important we're getting out good referrals, especially to this patient group, which has already suffered a lot at the hands of the medical community. So hopefully that will be helpful. And then, of course, as a dietitian, there are some supplements that I can offer, including fiber supplements specifically focused on soluble fiber. My personal favorite is psyllium husk. There's also peppermint oil capsules, which can be antispasmodic, help with pain, and digestive enzymes, especially if there's any FODMAP triggers. And evidence for diet, you'll notice that I highlighted the 2 last diets, which are the NICE and the FODMAP. That's because at this time, at least in my opinion, I love that we're researching diets more and more in this patient group. I think that there isn't really sufficient data at this point to be recommending some of these others. I think Mediterranean diet is always a beautiful option for just general health and well-being. Is there enough evidence out there that it's going to help a very symptomatic IBS patient? Not in my opinion. I'm more likely to go towards the NICE guidelines and towards low FODMAP. I know I'm running out of time, so I want to make sure that I finish up here. So NICE guidelines, for those of you who are not familiar, it's the National Institutes of Health and Care Excellence. It's basically the British version of the National Institutes for Health in America. And what I love about this is it's basic guidelines that are relatively common sense, but we often forget to give to our patients, and our patients may forget to use. And these can be a good first line diet and lifestyle advice before we go to elimination diets or strict diets. But you'll notice that in 2015, low FODMAP did get added to the list. And we've seen in evidence that both diets can be very effective for creating adequate relief in our patients. However, low FODMAP diet may be better for abdominal pain and for bloating. And I'm going to assume that most people who are watching this are pretty familiar with the low FODMAP diet, so I'm not going to belabor it. Low FODMAP diet, really question that I think we need to be asking as it pertains to this lecture is, what is the role of the low FODMAP diet in dysautonomia? So, at this time, there are no studies looking at a low FODMAP diet for dysautonomia patients, including its use in POTS. Evidence does show a connection between, as we've talked about, autonomic dysfunction and IBS. We also know that post-infectious IBS and long COVID have a role with each other. There was one study on hypermobile syndrome disorder with IBS on a low FODMAP diet did have greater decreases in abdominal pain and bloating. So it's really at the discretion of the dietitian at this time to decide if this is an appropriate protocol for their patient. And I would argue if the GI symptoms that they're presenting with, they've already gone through the testing, motility is maybe not their main issue, MCAS, which we're about to go into, is not their main issue, this is when a FODMAP diet may be appropriate for these patients. But we want to just make sure that we're not restricting more than is necessary. So again, just going back to our guidelines, we've got something that shows that diagnostic evaluation shouldn't be abused in this patient population. So just like we don't want to abuse it in our IBS patients, should not be abused in the Triad and Dysautonomia patients. Also, that the recommendation at this time is treat the most prominent GI symptom or abnormal test that happens. Again, I could advice 15 about diet on here, and that management of chronic GI symptoms require a team, right? So we know that we need to have the GI health psychologist on board, the pelvic floor physical therapist on board, as well as other parts of the care team that we'll talk about in a second. All right, to finish up, because I know we want to also have questions, mast cell activation disorders and histamine intolerance. So I want to start by giving a huge shout out to Cheryl Harris. For those of you who are not familiar with her, she's an amazing dietitian out of Virginia, DC, and Maryland. And I feel like she's just really, there's a lot of great dietitians. Kate Scarlotta deserves a shout out in this area as well. Definitely, the first dietitians to alert a lot of us to this condition. I just feel like Cheryl Harris is really moving the ball forward, gave a great presentation in April of 2025 that if you're able to get your hands on, I highly recommend. And some of the information in this part comes from what she presented. So what we're learning as we talk about mast cell activation syndrome is that it is just one of the histamine-related conditions associated with dysautonomia, that there's more going on here. And so we're starting to use the term mast cell activation diseases, in which MCAS is one of the conditions that comes underneath it. And really, this is where we have a normal amount of mast cells in the body. Mast cells are at any place that our body interfaces with the outside world, and they are releasing mediators, specifically histamine, for no known reason. Normally, it's due to some sort of an allergen. But in this case, these mast cells are blowing their tops and releasing a ton of histamine, and we don't always know why they're doing it. So as a reminder, histamine is a natural supplement substance. As I said, it's produced at places where our body interfaces with the outside world. It can be present naturally in foods, and it also comes as a side effect of food spoilage and food preservation. And histamine intolerance is a category that's being separated out from mast cell activation syndrome. I know, at least for me, I used to use those terms interchangeably, and I'm really learning that's not appropriate. They're different conditions. That with histamine intolerance, there is more histamine than the body is capable of eliminating. And this can be due for a lot of different reasons. Maybe we're not producing enough of the enzyme DAO that helps to remove it from the body, or maybe there is damage to the brush border where these enzymes are created. Maybe there's a medication or substance abuse of some kind that is injuring the area and making it hard for us to get those histamines out of the body. So there's a lot of overlap between MCAS, histamine intolerance, including symptoms and potential treatments. I think one of the main differences is where the histamine overload is coming from, possibly the role of diet. And I think it's also important to make note that diet is just one part of the equation, that when these patients overflow, when they hit their tipping point with histamine, food is just part of it. There's lots of other triggers. These patients can have it with extensive exercise. It may not even seem like a lot of exercise, but for them, it can really trigger more histamine. Chemical or odors, high temperature, especially really high heat, pollen, stressors. I know during the wildfires here in Los Angeles, a lot of my MCAS patients were really upticked in terms of their symptoms at that point in time. So just again, a couple of the symptoms that may be experienced by our patients. But again, it's really individualized. I think one thing that can be really interesting to ask your patients is when they have these symptoms, if they take an H1 or an H2 blocker, does it change the symptoms? And I've had so many patients who their GI symptoms go away if they take, or get significantly better if they take an H1 and or an H2 blocker. Well, this is a great sign that maybe this isn't irritable bowel syndrome. Maybe we're under the MCAS category, possibly MCAS. So what about diet? What do we do about diet? So what you're seeing here is a list of avoided foods according to a literature review on different versions of the low histamine diet that are out there, and then the count of how many times that foodstuff was suggested to be eliminated in that different histamine diet. And you can see at the top of the list are things like fermented foods, especially processed meats, sauerkraut, aged cheeses. Alcohol is up there, especially beer and wine, spinach, tomatoes, citrus, and chocolate, right? But I think it's really important that as a community, we understand, just like with SIBO, at this point, there is no one studied, evidence-based, low histamine diet or one approach that we can really offer to our patients. Now, with that being said, surveys of patients who have MCAD do say that they feel on average 50% better when they are following some form of this diet. Is it a placebo effect? Is there something about reducing the amount of histamine that's coming into their body? I think we're still figuring that out. So it's important we listen to our patients, we see how they're feeling, and part of the job of the dietitian is also to help them understand where the evidence stands and how can we work on opening the diet up as much as is humanly possible, as much as they are comfortable with, right? So this is reminding patients that diet is just one part of the equation. It's unlikely to be the lone solution. I yet in my career have had an MCAS patient where changing their diet solved all their problems. I would say diet, in my opinion, is way low on the totem pole compared to the medical interventions that are going to come from their allergy immunologist. And so we just want to make sure that we're keeping the diet. Oh, I'm so sorry about that. That we're keeping the diet as adequate and diverse as possible. And then just one last thing I want to say before we go into kind of finishing remarks is that there's also something to be said for upregulation and downregulation. And this is an area of study that I hope is going to become more complete as the years move forward. So what do I mean by that? So basically, a lot of our dysautonomia patients, they will come into your office. I mean, I've had this more times than I want to say, where patients will feel like everything is activating, right? And when they are in an active state, they're in an upregulated state, everything feels like a trigger. It's like a wildfire is going off when all they did was light a candle, okay? And this can happen for lots of different reasons, right? So again, it's not just food, strong smells, temperature changes, mechanical stimuli, friction, emotional distress, different kinds of medication, mold in their house. There's so many things that can go on that they light one candle, one thing gets activated, and all of a sudden the house is on fire and it just feels like everything is out of control. So I'd like to remind patients that food in these moments can feel triggering, but it may not be the food's fault. The food may just be caught up in this firestorm. And if we can start to downregulate any part of this equation, all of a sudden the food becomes less triggering. So I know I've been speaking way too long. There's a couple of these that we can go over. I really want to get into the best practices really quick. So as we talked about, helping your patient to create a care team, not just of providers, but of people who actually understand this condition and are not going to add to the gaslighting that this community experiences, really important. I think it's also important to come up with a comprehensive assessment tool. So this is part of one that we use at UCLA, and a huge shout out to my colleague, Sophia Spalia, who's helping to create this. Working with these patients, we need to understand what they've been through, what conditions they've been diagnosed with, how those conditions are being managed or not managed well, dive into the current symptoms, where might the symptoms be falling under this algorithm, and then really based on the patient's experience and our assessment, that can help to guide how we treat them. Also, we have this new best practices, which has some of the information that we can use. And I just wanted to put up there, if your POTS patients are not being well managed, and this is a place where dietitians can play a big role, getting their sodium intake to at least 3,000 to 10,000 milligrams, their fluid intake to 2 to 4 liters, possibly compression garments and exercise that is appropriate for these patients, can make a world of difference. And all of a sudden, their GI symptoms can get a lot better because, as we know, GI symptoms could be caused because POTS is not being well managed. We also have some resources that we can offer to our patients. And I think more than anything, offering them our compassion and our empathy, and above all, believe your patients. So this came from a gala event for the Los Angeles Dysautonomia Network. I'm a proud board member of this group. And you can see the types of comments that patients were making, and people who are supporting this group are making, that these patients can feel very alone unless they find their people. So in conclusion, dysautonomia is complicated, complex. It requires a team approach, lots of patient involvement, and a step-by-step guided nutrition plan that we can offer these amazingly brave, beautiful patients who are going to show up in our office. So even giving one tip or piece of advice that shows your patient that you hear them and you see them and you understand them. As I've mentioned, I've had patients over and over again say, do you have POTS? Do you have MCAS? And the answer is they don't. But I dive into these waters to be with these patients because they deserve to be heard and seen. So with that, here's my information. If you have any questions outside, I'm happy to stay on, though I know we're over. I'm so sorry, Eloise.
You are fine. You're fine. I think you're right in saying that every subsection that you have referenced today could be its own hour-long, 2-hour-long, 3-hour-long lecture. So thank you so much for covering so much in such a short time. And a lot of the comments in the chat are asking, like, when can we get the slides? When can we get these resources that you've mentioned? So I promise we will do our best as soon as it's done to collate this. And thank you for offering the slides as well to those who need it, because I think there's so many great resources in there. Now, we have just a couple of questions. I know we're at time. For those who want to stay on, we'll cover a couple now, and we will send the recording out. So we have a first question from Leah, which is back to your slide on dysmotility and the nutritional advice for dysmotility. She's asking, why whole flaxseed instead of ground, or do you make a distinction between the two?
It's a really good question, and I'm sorry I couldn't go more into it. So the research on ground, not just flaxseed, but any of these fibers, is that if we grind it into a powder, it becomes dry weight that's added to the stool. So we've just lost the whole point. Right? They did this. It's horrible. But the studies that were done on this were done in like the 80s, where they had patients take plastic particles in. And they did plastic particles of different sizes. And when they did any coarse or gritty form of plastic, it helped them poop. And as soon as they pulverized it into a powder, it constipated them. So what we've learned is it's better to do a pulverized form of those types of fibers for diarrhea patients, not so good for constipated patients, which is probably what you're going to see more in Dysmotility. At least from the lower perspective.
Yeah, thank you for clarifying that. Courtney just wanted to confirm, who was the RD you mentioned in DC for MCAS? I think it was Cheryl Harris. Is that correct?
Oh, yeah. Cheryl Harris is amazing. Kate Scarlott is amazing. They both have presentations coming up. And then I think, is it Nikki Straley, I think, is going to be presenting at Fancy. I mean, the community that we have of dietitians is astounding. And we're really all diving in to understand this and help each other. There's a lot of great presentations coming up that I feel like for people. And again, feel free to email me if you want more of this information. Happy to send that anything.
Lovely. And I just wanted to throw my own question out there as well. So given you're working in the nutrition and dietetics space, if you have a patient come to you who hasn't had that formal diagnosis yet, but you are suspecting there's some sort of dysautonomic underlying issues happening, how much of a role do you play in guiding them back to the right care team? Like, do you really take that on as your responsibility, or how do you manage that?
Yeah, I've become the quarterback for a lot of patients. I try and move them to a really good primary care physician. So that's usually my first point of reference, is find a primary care physician who is willing and able to be that quarterback for the patient. But I will then often make suggestions to that quarterback of, here are providers I think this patient may need to see. Something that I love from the Los Angeles Dysautonomia network is every year they create reference list of providers that patients feel like did not gaslight them and actually took care of them. And they send this out to everyone. I don't know if it's available on their website. I'm happy to share it if anyone wants it, but it's local, so it's not going to help a lot of you who are far away. But anyone who is semi-local, if you need a good referral list, I mean, these are patients saying to other patients, these people took care of me. They knew how to take care of me, which is so valuable.
That's great. That's great. And the Australian definition of quarterback, I'm not sure that would be a full forward in football, potentially.
Oh, I'm so sorry.
That's fine. That's fine.
Yeah, the main provider who is one that is out and helping to coordinate. Used American lingo there. That's terrible.
You're fine. All right. I think that that's all the questions we have for now. Hopefully everything else has been answered in the chat. But just again, another huge thank you, Nancee, for your time, for covering all of this, and for the amazing references and resources that you brought to us today. I'm just going to bring up a little questionnaire for anyone that's still on the line and wants to fill out just some feedback for us. And we will also share that in the follow-up email. And until next time, we will be back with another Nerva webinar next month. So keep an eye out in your inboxes. Thank you so much.